up, everyone? Welcome back to the Daily Sean. Those of you who haven't been here before, my name is Sean. I do a daily video on something related to nursing. There's no rhyme or reason. Probably won't change. Today's subject is sort of a fan question or request. Someone wanted me to talk about pain management, pain scale management with our patient. I'm titling this particular video, "The Pain Scale Sucks." It's not reliable in any way. I'm going to give you 10 things to think about when dealing with your patient's pain. 10 things that are going to skew and complicate how you manage your patient's pain. Number one, pain is different on the type of pain and the location of pain. Keep that in a frame of reference when you're treating your patient's pain. Surgical pain, visceral pain, musculoskeletal pain, all are going to feel differently and should be treated differently. Do not treat someone's headache the same way that you treat surgical incision. Common sense 101, but I feel the need to say it out loud. Number two, each patient is going to feel pain differently. It has to do not only with the patient themselves, but their interpretation of pain. How I feel about my pain is very differently than how you feel about your pain. It's very different than Aunt Bo versus Uncle Chad. Once again, just keep it as a frame of reference. You don't judge, prejudge, or criticize how someone describes, interprets pain. Number three, make sure you know what type of pain you're treating, acute or chronic. It's also just a modifier of how you're treating your patient's pain. Is it acute versus chronic? You're going to treat them very differently when someone says, "I'm having pain." Is it a pain that's been there before, or it just showed up and oh my god, I'm dying? Leads me into number four. The scale of pain sucks and it's horrible. 1 through 10 is the most generalized, abused rating system, yet we still have to use it. I would encourage you to use it only as a frame of reference. Do not use it as an absolute. My level of 10 is not your level of 10. My level of 7 is not Auntie Joe's level of 7. Uncle Buck's level 5 is not my level of 5. It is not an absolute number. A headache 5 for me is not a headache 5 for you. All common sense, but I feel the need to say it out loud. Who the hell is Auntie Bo? Uncle Chad? Really? Number five. 5. Number 5, using a frame of reference when describing your pain. When you ask a patient if they're having pain and they say yes, on a scale of 1 to 10, it should follow up with the frame of reference. What is a level 10? What is a level 2? A level 10 for me would be my broken leg or a broken femur. That's a level 10. Having your finger ripped off from the socket, that's a level 10. A level 2 is a dull headache. A level 2 is, ooh, that smarted a little bit, like when you stub your toe. Not when you break your toe, when you stub your toe, when you jam your finger, or when you get a splinter. Give it a frame of reference so they have some sort of idea of what you're asking for. If you allow them, what kind of pain are you having? Level 10, I'm dying! Put me out of my misery! See what I mean? Once again, frame of reference for what a 10 is versus what a 2 is. Don't just say, give me a number. Number 6, do not judge them. Do not prejudge someone by their history, by their description. You are not there to judge them about their pain. You're there to help them with their pain. This is a very difficult concept to grasp, very difficult concept to practice. We all judge. We all have done it. I have done it. I still try not to do it, but we all judge. Try your best not to judge someone when they're talking about their pain. Unless you are feeling what they are feeling, you cannot judge them. The patient's pain is what they say it is, when they say it is, and how they say it is. Number 7. 7? Yes. Number 7, their history matters. Past medical history. What kind of pain management have they had in the past? Are they dealing with chronic pain? Do they take medication? There is such a thing as pain tolerance, narcotic tolerance, abuse, frame of reference again. How much pain medication they may require before they get relief. safe. If you give me 10 of Oxy, I'm probably going to be slobbering on the floor. But if you give 10 of Oxy to someone who has been on a morphine patch, it's probably not going to affect them much. Their receptors are a little desensitized. Frame of reference. Giving me a milligram of Dilaudid might have to intubate me. Give someone else a milligram of Dilaudid who is a cocaine user, probably not going to hit them very much. Number 8, trust matters. The trust that you develop between you and your patient will matter. If your patient trusts you, they're not going to abuse the system. Vice versa. If you trust your patient, you're going to trust them that they're giving you their honest assessment. Trust matters. It is your job to try and establish trust. If you fail, you are going to chase your tail. You are going to constantly question what's going on in regards to your patient's pain management. Not only question your decisions, but question theirs. Number 9, do what you say you're going to do, when you're going to do it, and how you're going to do it. Do not show up in your patient's room and say, I will be back in 20 minutes to give you your pain pill, and 45 minutes later you show up. If you're going to be late, if you have something that stops you from getting there in that 20-minute time frame, update your patient in some way. Send someone into the room, the CNAs, the techs, the UAP, send them into the room so that they can at least be informed, so that you establish that trust with your patient. Keep them informed. If you cannot get to them, if you cannot give them their pain medication in a timely manner, ask for help. Ask for a coworker to manage their pain. Give them their breakthrough medication. Whatever the case may be, make sure that you do not lie to them. Do not tell them you're going to do something and not do it. Once again, establish trust. Number 10, empower your patient to make these decisions. Don't give them absolute answers to questions. You're going to give them choices. You either get to do this or you get to do that. You don't get a third option of not doing anything at all. You can either have the Tylenol or you can do some mobility. There has to be a give and take. Do not give them absolutes. Do not give them an easy out. Give them the ability to help manage their pain. Allow them to contribute to the management of their pain in some way. Give them some empowerment. It will do wonders for managing their pain. If they feel helpless, if they feel that they have no control, they are going to just want to be over-medicated. Empower them to help manage their pain with you. Get help from the patient themselves. Pain management is a difficult challenge, regardless of who you're taking care of, whether they are a walkie-talkie chronic pain management or it's intubated and sedated and have multiple injuries. Pain management is difficult. Number 11, bonus tip, do not use vital signs as your only means of pain management assessment. Do not use vital signs as the only way to assess if someone's having pain. Just because someone's not tachycardic, not hypertensive, doesn't mean that they're not having pain. Do not use vital signs as the only means of pain assessment. Just because your patient can't talk to you, they're on a ventilator, and they can't tell you they're in pain, doesn't mean they're not in pain. Utilize another system. What do you think? What'd you think of this episode? 11. I gave you one bonus. 11 tips for managing your patient's pain. Do you have anything to add? What did I miss? I always want to hear from you. Leave a comment below. You like it? Hate it? Did you love it? Do you think the video sucked? Love hearing from you. Always love a thumbs up. Share this with somebody. And as always, check your own pulse first.